Thank you, Steve. Likewise, I am honoured to be here with you today in person, and especially honoured to be giving the David Cooper Plenary Lecture. In the next 30 minutes or so, what I'm going to try and do for you is synthesize some of the astonishing amount of data that we are seeing come out around possibly one of the most perplexing and challenging aspects of the COVID-19 pandemic, and that is long COVID. Now, I've been talking about long COVID for the last couple of years, but I always like to start actually with a slide which reminds us of the origins of long COVID, and it's been termed the first patient-made illness. And what that really reflects is it is patients themselves and the community themselves that really identified to the medical and scientific community that there was an ongoing post-COVID illness in a large proportion of people that was not really being taken much notice of. And through social media, blogs, survivor groups, etc., this growing group internationally of patients who came together as long haulers. And it really took the medical community some time to recognize this. It was lent some weight by some prominent physicians who themselves suffered from this illness, notably Professor Paul Garner, an ID physician at the London School of Tropical Medicine, who wrote about his own experience in the BMJ early in May 2020 of a post-COVID illness. And the actual name long COVID comes from a hashtag on Twitter by a doctor, Dr. Eva Perego, who is at the center of the Lombardy epidemic, who wrote of her own illness, having acquired COVID-19. So this name, long COVID, has really stuck. It has also been given other sort of scientific names by the medical community since, post-COVID illness or PASC. But it is really long COVID, the name that patients first gave it, that has maintained. And it's interesting because a search on PubMed of articles actually shows not only an astonishing amount of new articles by year around this subject, but that most of them are found under the search term long COVID and not PASC. And I think that's really important to recognize that for patients. One of the first questions that comes up is how common exactly is long COVID? And this is incredibly important for public health systems, health services to understand the potential burden on their services going forward. And there's been a lot of confusion about how common this illness is. In 2020, there were vastly differing estimates in prevalence from around 2 to 3% in some app-based studies to 80, 90% in some studies that were coming out of survivors who were coming from ICU. But clearly, there were very different populations in these studies. Some were community-based, some were hospital-based. There were small numbers. There was a lot of selection bias in terms of the patients who were included, whether they self-referred into the studies, etc. And there were major diagnostic and testing issues with availability of testing to confirm infections. As the pandemic has gone on, I think we start to get some certainty of strength around the estimates of true prevalence. And that comes from large data sources, of which the Office of National Statistics in the UK is one source. Now, this asks, in a COVID infection survey, it asks participants who have identified as COVID positive in the UK whether they self-identify as having ongoing symptoms not due to anything else at a period of time post-COVID-19. Between April 2020 and March 2021, they asked 20,000 study participants who had tested positive whether they had ongoing symptoms for at least 12 weeks, and the prevalence was around 14%. And 10 to 20%, I think, is around the prevalence that we're seeing in the unvaccinated individuals. Now, interestingly, this is 8 times higher than in a control group of the general population, so it's really important that this doesn't just reflect ill health in the general population. Of course, as the pandemic has progressed, we see different variants. We also see the effect of vaccination. So it's important to have up-to-date estimates of prevalence as we move forward through the pandemic. And this is the same survey that asked that same question, but more recently, this was reported in July 2022, after infection predominantly with the Omicron variant. And there you can see in the light blue, the triple vaccinated individuals, and in the maroon, the double vaccinated individuals. What this says is that with double vaccinated individuals, the prevalence of long COVID self-identified dropped by about half in the context of Omicron, to about 4%. In the context of triple vaccination, however, with any variant, Omicron or Delta, the prevalence of long COVID is sitting at a fairly certain 4 to 5% of individuals. Now, this data is important to look at globally, and there have been some attempts to do this. This was a paper published recently in JAMA. It was a Bayesian meta-analysis that took account of 54 studies and 2 databases, including a very large VA database, across 22 countries. They were mostly high-income countries, and they looked at the prevalence of long COVID. And it was sitting at about 6.2%. So again, consistent with that data from the UK statistics, gives us some certainty that this may be around the true prevalence. Notably, however, there is limited representation from some regions, particularly low and middle income countries, and I think this is a major data gap in what we know about the prevalence of long COVID. Of course, it's very hard to ask how common long COVID is without understanding what long COVID is. And as time has gone on, it's clear that there are a myriad of symptoms that can be identified as belonging to a long COVID diagnosis. In fact, over 200 symptoms have been attributed to long COVID, but there are clearly some symptoms which become more common or recognized more frequently. Fatigue, an intense relapse in fatigue being the major predominant symptom. Others such as headache, brain fog, smell, taste disturbance, respiratory, cardiovascular symptoms. These are all common symptoms, but clearly any one of a number of symptoms belonging to any body organ can be attributed to long COVID. And in an effort to try and come up with a consensus definition, the WHO did conduct a Delphi process in October 21 and came up with this. Post-COVID-19 condition or long COVID occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. So clearly this is a very broad catch-all definition. It has to be so to not exclude patients with long COVID, but it does create some difficulties in trying to understand what truly is long COVID and how to treat it. Now, as we've gone through the pandemic, the use of very large databases and electronic medical records has really helped us understand a little more about the patterns and risk factors for long COVID. This was a paper in Nature Medicine last year, a really nice paper looking at UK primary care records in non-hospitalized patients and the ability to look at hundreds of thousands of patients. So this study looked at around 500,000 patients who had had COVID-19 diagnosed and matched them on key variables with almost 2 million individuals who had not had COVID. And they were able to identify 62 different symptoms that occurred more commonly in those who had had a COVID-19 diagnosis, as opposed to the general population. When they looked at risk factors for long COVID by the WHO definition in this study, there were key risk factors, and these have been replicated by and large in many other studies, particularly women being female as a risk factor for long COVID, also in this study being Black or of other non-white ethnicity, having a BMI of greater than 30, being a current smoker, and coming from a more socially, economically deprived situation. Now, many of these risk factors have been replicated, some but not all. For example, this was another Scottish population cohort. Very large numbers of individuals, 33,000 positives, 62,000 without COVID. Long COVID at 6%, again, giving us some confidence that that probably is about the right prevalence of long COVID in our populations. The risk factors for long COVID, again, female gender, initial severity of illness, presence of comorbidities. In this study, white ethnicity, but remembering it's a Scottish population, might be quite different, and increasing age. The paper in Nature Medicine was quite interesting because what it also was able to do, which I think is really key as we move forward, was to try and look at different phenotypes or presentations of long COVID. So in the around 50,000 people who had long COVID at 12 weeks, they used latent class analysis to try and cluster people by their presentation. And here you can see 3 classes or clusters that they derived. The size of the text is proportional to the frequency of the symptoms that those people in that class were reporting. So class 1, most people fell into a sort of fairly disparate class of symptoms, many different symptoms, but mainly fatigue, headache, some abdominal pain, etc. About 80% of people fell into that very broad class. But then there were 2 other classes of presentation. A small group of individuals who presented with a predominantly cardiorespiratory type presentation, cough, shortness of breath, phlegm, and then a class 3 presenting with more neuropsychological and neuro-COVID type presentation with insomnia, cognitive difficulties, anxiety, depression, and so on. So although this is very early work, it starts to allow us to pull out that there may be different types of long COVID, and that is really helpful for trying to understand pathogenesis. Because long COVID is likely to be several different syndromes. We're very aware that post-intensive care sepsis recovery syndromes exist, and people who've had organ damage from severe pneumonia or other organ damage are likely to spend a long time recovering. But the more esoteric presentations of long COVID or novel presentations, the POTS type syndrome, the autonomic dysfunction, the post-viral syndrome with intense relapsing fatigue, similar to maybe more like a chronic fatigue or an ME type presentation, the neuro-COVID type presentation with brain fog. These are all probably different phenotypes and may have underlying different pathogenesis. And understanding those different long COVID phenotypes is going to be critical for our future management of the illness. So what does cause that long COVID syndrome, particularly the more post-viral neuro-COVID type presentations? I think we're a long way from understanding as of yet. There are many different proposed mechanisms through from the presence of microclots to the human herpes virus reactivation, gut dysbiosis, etc. And I'm not going to have time to go through all of these different mechanisms, but I do want to present a little bit of data from our own lab at Kirby that we've worked on with Tony Kelleher that gives us some clues from basic science. So ADAPT is a cohort that we started at St. Vincent's Hospital following patients who had had COVID-19, whether they were recovered or not. We followed them from their acute illness and took repeated measures, clinical symptoms, questionnaires, but also blood work, including PBMCs at defined time periods during a prospective cohort. And allowing us to do this meant that we could really do a very elegant sub-study on the immunology of patients who had had COVID, comparing those patients, 31 patients we took in this sub-study who had long COVID with ongoing symptoms. We age and sex matched them with 31 individuals who had had COVID but were asymptomatic in recovery. We had 25 patients who had had prevalent other coronaviruses at the same time as the people who'd had COVID, and we had 16 healthy controls. And we examined their blood work at 4 and 8 months post-diagnosis. Now, this work was published in Nature Immunology, and it's quite intense. I'll go through it in fairly brief detail. You can see here 3 panels. Panel A, activated monocytes, B, plasmacytoid and dendritic cells, and C, the type 1 interferons, interferon beta, interferon gamma. I'm going to just concentrate on these. You can see here in red our long COVID patients, in blue our matched controls, and in fact at 3 to 4 months post-infection, both of these groups had an activated immune profile with elevated type 1 interferons that we wouldn't expect to be activated so far out from an initial viral infection. Now, more interestingly maybe is that those patients who had long COVID, their immune profile remained activated out to 8 months. You can see here in the red, at 8 months, these individuals still had an activated immunological profile compared to the people who had recovered whose immunological activation had settled back down to basis. So this clearly suggests that something is providing antigenic stimulus, immune activation to patients with long COVID. And it was really important because it was one of the first papers, I think, that gave some biological validation, particularly to patients' symptoms, and really started to try and maybe understand pathogenesis. We also importantly saw an absence of naive and B and T cells in those patients with long COVID, again suggesting that something was activating the innate immune system and causing a degree of immunological exhaustion. Now, what could that be? There are different theories, but I think there is increasing evidence behind the theory that there may be viral persistence, and this may be driving at least some of patients' long COVID symptoms. This is just a nice paper, I think, from gastroenterology looking at virus in gut. This was 46 individuals who had inflammatory bowel disease, and they had had COVID an average of 7 or 8 months previously. They were undergoing routine colonoscopy with biopsy. Some of them had ongoing long COVID symptoms and some of them didn't. And the investigators took gut biopsies. What they were able to show was that about 3/4 of them had ongoing RNA expression and around half had evidence of nucleocapsid antigen persistence by immunoreactive staining in gut biopsies. And importantly, it correlated very strongly in a blinded fashion with those individuals who had ongoing symptoms, the presence of antigen persistence. So starting to disentangle what may be behind patients' symptoms. This is just some other intriguing data from ADAPT. The kynurenine pathway is a pathway of macrophage activation and release of kynurenine and its metabolites quinoloic acid. These can traverse the blood-brain barrier and cause neuroinflammation and have been proposed as the indicators of a number of neurological conditions related to inflammatory response in the brain. Here we see in ADAPT again 123 patients and controls, and what we see there in the red areas is the elevated kynurenine and quinoloic pathways at some months post-infection in the long COVID cases compared to our controls, as well as some controls with ME and chronic fatigue. So clear evidence of some neuroinflammation and some biomarkers that may be of importance. And although this is very early work, it is important because it starts us on the pathway to thinking about therapeutic intervention for long COVID. Unfortunately, the current landscape for therapeutic intervention for long COVID is pretty depressing for patients, at least. There are many drugs that are being studied. From clinicaltrials.gov, a month or so ago, 168 interventional trials when I looked for long COVID or post-COVID illness. Approximately a third of those were drug interventions, and you can see the very broad range of different drugs that are being proposed as potential therapeutic interventions for long COVID, and they range on the left from things that are fairly standard, steroids, statins, metoprolol, colchicine, to the more esoteric on the right, dietary supplements, cannabis oil, mesenchymal stem cells, etc. And then we have things like hyperbaric oxygen, a very broad range of therapeutics. And this says to me that nobody really understands how to start to treat long COVID. I am just going to mention, however, Paxlovid, because I think this is obviously a drug of interest, particularly given viral persistence is a possible mechanism. And this was a short report of 4 cases by Steve Deeks' group published last year, suggesting that Paxlovid improved symptoms in these 4 cases, but it was given obviously at variable intervals. And they weren't proposing that it should be used, but they did set out a rationale for the use of Paxlovid in systematic studies for the treatment of long COVID. And in fact, there are now 2 RCTs commencing this month on the use of Paxlovid for people with long COVID, one from Duke University as part of the NIH-funded Recover COVID initiative, and a smaller study at Stanford University. Both of these are studying a 15-day course of Paxlovid versus a placebo, and will recruit over a year with a primary outcome of symptom scores. in the UK, which has really taken a lead at doing adaptive platform studies for acute COVID-19, a consortium of many researchers have come together to form something called Stimulate ICP, with an adaptive platform study looking at treatments for long COVID, commencing at 6 clinical sites in 4,500 individuals. And they're looking at 3 different arms: a combination antihistamine arm, an anticoagulation arm, which may speak to the theory of microclots, and an anti-inflammatory arm. And the beauty of adaptive platform studies is they have the ability to drop or add arms depending as the field moves on. So some large RCTs are beginning, but unfortunately they're not going to give us any answers for another year or so, I think, at least. So where does that leave us and our patients? Primarily with non-drug interventions are key, and they should be patient-centered. They should be personalized because of the individualized presentations of long COVID, and predominantly should be multidisciplinary. And I'm sure in many of your centers, long COVID clinics are beginning. Certainly in our long COVID clinic, we begin with a thorough symptom assessment to rule out any treatable comorbidities that may be due to COVID-19 or coincidental. So some very simple blood work, nothing unusual. I have to say most of this is often negative and doesn't turn up any surprises, but occasionally it does. Things like a chest X-ray, echo, CT, depending on symptoms. Neuropsychological assessment is really important for anxiety, depression. These are potentially treatable. Sleep impairment is a very common feature of long COVID, and also cognitive dysfunction. And then the consideration of a personalized rehabilitation program working with physiotherapists, psychologists, etc., but primarily also including the patient in this. There are many guidelines for treating long COVID. This is just one from the British Journal of General Practice. But here you can find, and there'll be similar ones probably in other settings, and they should be tailored to your country setting, but advice on how to manage tachycardia, for example, how to manage the symptoms of POTS, how to manage respiratory issues with breathing exercises, and what to do about low mood, etc. So it's really a targeted symptom management process at the moment. Of course, the best way to treat long COVID is to prevent it in the first place, and there are 2 real arms for that. One is vaccination, the other is antivirals. I alluded to the fact that vaccinated individuals were protected somewhat from long COVID right at the start, and a systematic review of 11 studies published recently has demonstrated that this is the case. 6 of 11 studies showed benefit, the other 4 showed no benefit or harm, but in the 17 million individuals that showed benefit, the reduced risk was between 15 and 42% of long COVID sequelae. So clearly vaccination is not only important for acute illness, but very important for long COVID prevention. Antivirals for long COVID, and Sharon mentioned this study earlier. This is Paxlovid given in acute illness in the VA database to non-hospitalized patients who were at high risk of acute illness, showing a reduced risk of PASC with a hazard ratio of 0.74, about 25% risk reduction, and the effect maintained across all subgroups. But remember, these are individuals who are already at high risk of acute disease. So maybe not surprising that if you reduce their acute disease, you reduce their long-term sequelae. What it doesn't tell us is the people who have mild disease who may not qualify for Paxlovid, whether antivirals in that setting helps reduce the risk of long COVID down the track, remembering most people with long COVID have mild disease. Finally, the long-term outcomes of long COVID are unclear. I'm just going to show you this, just a bit of a taster, data from ADAPT 2 years. So this is immunological data, does suggest that there is some resolution. We've looked at these same patients that we looked at 4 and 8 months in our Nature Immunology paper, and does suggest that we may be seeing some resolution. The activated signal, by and large, has reduced, so the long COVIDs are now similar to the match controls at 24 months, and that loss of naive T-cell subsets has resolved. So at least from an immunological perspective, we start to see some resolution. Now, tying that to patient symptom improvement and long-term clinical outcomes is much more challenging. What does the future hold and what is required? I think it's important to remember we're at the start of a very novel illness and there is much still to learn. It's only 2 years since global bodies such as the WHO really acknowledged that we were going to have a significant long-term impact in our population of long COVID, not only on health services but also an economic impact and on the mental and physical health of large proportions potentially of the population. There are therefore many future needs and challenges. The first is a continued exploration of the pathophysiology and mechanistic studies of long COVID, because I think without this we do not understand what we are treating, and we need to have a better understanding of what long COVID really is or is in different scenarios. The development and validation of biomarkers would be really critical for patients, but also to monitor the effect of our therapies, which at the moment rely on improvement in patients' symptoms. The expansion and funding of therapeutic studies is urgently needed. There are some RCTs coming through, but we need to have other therapeutic options being explored in case these do not give us the answers. We need to have ongoing large-scale epidemiological evaluations, including what happens with repeated risk of reinfection to long COVID, and what are the long-term outcomes on organ damage and morbidity at a population scale. And finally, we need to make sure we include in our research the diverse populations who may be more at risk of long COVID, including women, people of colour, and people from low-income backgrounds. These people typically underrepresented in most research. And I'll leave you with this final quote, which comes from a couple of researchers, again, Dr. Eva Perego, the doctor who coined the hashtag long COVID. And it says, how scientists engage with knowledge about new diseases affects how meaning about a disease accrues, how terminology solidifies, and which evidence is prioritized. And what this really means is that as we move forward, and we've still got lots to learn, is we continue to work with our patients to understand what long COVID is. And I have no doubt, this is the Cooper Memorial Lecture, I have no doubt that if David was with us today, he would do exactly what he was doing in HIV, working with his patients to understand the challenges of long COVID going forwards. Thank you.